Going to talk on laparoscopic ports and basics of insertion. Dr. Sushant Naik.
Basics of laparoscopic port insertion. Starting, we'll go for the position of the patient, which includes of stirrups or Lloyd Davis position in pelvic surgeries and Trendelenburg position in in abdominal surgeries. But these two positions will be taken after entry of the port, and the entry of the port will be in a supine position. So the operating table should be horizontal at the start of the procedure, and the abdomen should be inspected for any scars and palpated to check for any masses before insertion of the Veress needle. There are two types of port entry seen. One is the primary port closed entry, and the other one is the open port entry method, which I'll explain later. In the primary port closed entry, the two types of entry will be seen, and that is infraumbilical or supraumbilical. And majority of the surgeons prefer infraumbilical entry, and umbilical entry is mainly used because it gives a fixed peritoneum. It's thin comparatively, least vascular, and cosmetic approach is also achieved. The primary incision for laparoscopy should be a smile incision from the base of the umbilicus, and keep it in mind it's not in the skin below the umbilicus, it's on the inferior border of the umbilicus, and the care should be taken not to incise so deeply as to enter the peritoneal cavity. Patency of the Veress needle should be checked once before starting the procedure. And once we go for insertion of the Veress needle should be held in a pencil grip or a Darton-like grip position. And initially on the skin, we place the Veress needle vertically, and then as we go deeper, we hold it, angle it towards the pelvis. And the surgeon who will be performing the surgery, he'll experience a double click on entry of the Veress needle, and once there's a double click experienced, it confirms the presence into the peritoneum. The plane incision will be mid-sagittal plane for the Veress needle, and any lateralization apart from the mid-sagittal plane can cause injury to the abdominal vessels. And the Veress needle should be sharp with a good and tested spring action. A disposable needle is recommended. The lower abdominal wall should be stabilized in such a way that the Veress needle can be inserted at right angles to the skin, and elevation of the anterior abdominal wall at the time of Veress or primary trocar incision is not routinely recommended, as it does not avoid visceral or vessel injury, but it's practiced. And the angle of the Veress needle insertion, it varies according to the BMI of the patient. That is, in obese patient, it's approximately 90 degrees, and in non-obese patient, it goes to 45 degrees. The two audible clicks heard on entry of the Veress needle. First one is on the on piercing, or as we cross through the rectus sheath, and the second one is on piercing the peritoneum. Excessive lateral movement of the needle should be avoided. This may convert a small needle point injury in the wall of the bowel or the vessel into a complex tear. And waggling of the Veress needle from side to side must be avoided again, as it might enlarge a 1.6 mm puncture injury to an injury of approximate 1 centimeter in the abdominal viscera or the blood vessels. Indicators of a safe Veress needle insertion. There are primarily 4 tests we can go for. The first one is the needle movement test, in which the Veress needle, once it's inserted, we can check for movement of the Veress needle in all directions, and if there is any free movement, it confirms the presence into the peritoneum. If there is any difficulty or rigidity, it can show a sign of having entered a viscera or any vessel. Second is the irrigation test, in which a 10 ml syringe is filled with saline is taken, and through the Veress needle we infuse 5 ml of saline, and if there is a free movement through the Veress needle, it confirms presence into the peritoneum. Third is the aspiration test. With the same syringe, we can pull back the piston, and if there is clear air coming out, it confirms the presence into the peritoneum. And the fourth one is the hanging drop test. That is, with the same the syringe, we can put drops of saline over the Veress needle, and due to the negative pressure of the peritoneum, we can see the drops going in freely into the Veress needle, again confirms the presence into the peritoneum. The most valuable test of correct placement of the Veress needle is to observe that the initial insufflation pressure is relatively low and is flowing freely. The Veress intraperitoneal pressure is a reliable indicator of correct intraperitoneal placement of the Veress needle. Therefore, it is appropriate to attach the CO2 source to the Veress needle on the entry itself. Insufflation, we have to set the pressure to a cutoff of 20 mmHg. Start at a low flow rate of approx 1 liter per minute. Check the gas entering at a low pressure, which is approximately equal to or less than 8 mmHg, and after 0.5 liter flow rate can be increased further on. So we have to set after that the insufflating pressure cutoff to 20 mmHg. Again, the 20 mmHg value differs based on the different surgeries which we plan for. The greater the gas bubble and abdominal wall tension, the less the risk of bowel injury. Here we can see if the abdominal pressure which we maintain, if it is at 8 mmHg, it causes tenting of the abdominal wall, hence causing or more prone to injury of the abdominal vessels or the viscera. And if the abdominal pressure is equivalent to 20 mmHg, it creates a cushion of CO2 above the viscera and below the peritoneum, hence preventing the injury. In a routine practice, the surgeons usually, while applying the conventional trocar which we use, a 3 kg force is approximately used on entry for the entry of the trocar or the varus needle. And a 3 kg force in a patient with an intra-abdominal pressure of 20 mmHg, it prevents the injury to the abdominal vessels and viscera, because there will be almost a 4 centimeter penetration into the abdomen. Whereas in any pressure of approximate or less than 15 mmHg, the tip of the trocar will touch the abdominal contents. An intra-abdominal pressure of 20 mmHg should be achieved before inserting the primary trocar. The volume of CO2 inserted with the varus needle should depend on the intra-abdominal pressure. Adequate pneumoperitoneum should be determined by a pressure of 20 mmHg and not by the CO2 volume. The distension pressure should reduce to 12 to 15 mmHg once the insertion of the trocars is complete. In the varus needle method of entry, the abdominal pressure may be increased immediately prior to the insertion of the first trocar. The primary trocar should be inserted 90 degrees to the skin through the incision at the base of the umbilicus, and then we'll angle it towards the pelvis or to the targeted organ. And once the laparoscope has been introduced, it should be rotated throughout 360 degrees to check for any adherent bowel. The trocars which are in the market right now or used by the surgeons, on the left side is the conventional trocar and cannula, which has either pyramidal or conical tip. Then on the right top we have the disposable shielded trocars. Then below that we have the Hassan's trocar, which is used in open port entry system. And then we have the most recent advanced method used, that is radially expanding trocar, that's the Versa step. Secondary ports, these are inserted under direct vision, and an inadvertent injury from a secondary port could be considered negligent. And the main principle while going for secondary port entry will be to avoid the inferior epigastric vessels, to avoid the bowel or vascular injury, and to minimize the hernial risks. Secondary ports inserted under direct vision at right angles to the skin at a 20 mmHg pneumoperitoneum. Anterior abdominal wall vessels should be visualized laparoscopically prior to secondary port placement, and once the trocar has pierced the peritoneum, it should be angled towards the targeted organ. This is an example I am giving. The first laparoscopy picture shows the left inferior epigastric vessel and the site selected for the insertion of the trocar, and the second image we have inserted the trocar having lateralized the left inferior epigastric vessels. This is an image showing the benefit of having maintained a pneumoperitoneum. If we maintain a proper intraperitoneal pressure on insertion of the trocar, we can prevent the injury of the abdominal vessels. And alternative for primary port will be seen if at all there are conditions like previously midline laparotomy has been operated in the patient, in a very slim or morbidly obese woman patients. If the saline test fails or there is 2 times varus insertion failure, unsatisfactory closed varus insufflation, and the alternatives for the primary port entry technique will be the open entry variation of Hassan's technique and Palmer's point closed entry technique. In Palmer's point, the Palmer's point is the preferred alternative trocar insertion site, except in cases of previous surgery in this area, that is the left upper quadrant, or in case of splenomegaly. And in Palmer's laparoscopic entry should be considered in the patients with suspected or known periumbilical adhesions or history or presence of umbilical hernia, or after 3 failed insufflation attempts at the umbilicus. Other sites will be the trans-cul-de-sac portal entry and transuterine. Coming to the Hassan's open laparoscopic entry method, direct entry is done without creating a pneumoperitoneum, and the insufflator is connected. Here we'll go for an incision below the umbilicus. We'll directly open the layers of the umbilicus, and we'll, after visualizing the bowel and the omentum, we'll go for the port entry. And once the blunt trocar is inside, the abdominal cavity comes under direct vision. When Hassan open laparoscopic entry is employed, we confirm that the peritoneum has been opened by visualizing the bowel or the omentum, and the open entry technique may be utilized as an alternative to the varus needle technique, although the majority of surgeons prefer the varus entry. Direct insertion of the trocar without prior pneumoperitoneum may be considered as a safe alternative to the varus needle technique. This comes with experience of the surgeon, and it is associated with less insufflation related complications of the air of the gas that is used, like CO2, where we can see gas embolism chances, and also it is a faster technique than the varus needle technique. Shielded trocars may be used in an effort to decrease entry injuries, and there is no evidence that it is better than the varus needle method. And having done with the surgical procedure, in that exit techniques, these should be done under direct wave to identify the bleeding, injury to the omentum of bowel, or injury to the viscera. Secondary ports must be removed under direct vision to ensure that any hemorrhage can be observed and treated if present on removal of a laparoscope. Checking by direct visualization that there has not been a through and through injury of bowel adherent under the umbilicus. For wound closure, proper closure of the fascia within umbilical port site is done to prevent wound dehiscence or hernia, and avoiding hernial risk by closing the rectus sheath should be done in midline port sites of more than 7 mm and in lateral port sites of more than 5 mm. Thank you.
So any questions from audience? Okay, sir.
I think the only point I would not agree with him is the 20 millimeter of mercury pressure in the abdomen, even in the beginning when you are going to put in first port. I think it will carry more risk of cardiovascular compromise, even with 14 millimeter or even with lower pressure insufflation. There is risk of bradycardia in some patients, particularly elderly patients, so you have to keep actually lower pressure. So I think avoiding first port related injuries you can avoid by lifting the abdominal wall a little bit, and do not use lot of force while depressing the abdomen. So you can use your hand with a little movement like this, and as soon as you enter the peritoneal cavity, stop there. So no extra force, because you are not going to do the gymnastics there with the patient. So no 20 millimeter mercury pressure intraperitoneal, even for first port insertion.
Actually, sir, for different procedure based on
You
the
can ask,
surgery.
there might be laparoscopic surgeons sitting here, how many use it? In last 30 years, I have never used it.
What precaution will you take? What precaution will you take before placing your first port on the palmer's point? If you place your first port on the palmer's point, you said, then what precaution will you take?
Initially, for the preparation of the patient, we'll make sure if the stomach is empty. We'll go for RT tube insertion.
Eyes to
Ji.
What do you do if a bleed happens while putting a trocar? You put a 5 mm, you have put a 10 mm, now you put a secondary port and you see blood gushing out. What do you do?
We won't move the trocar. We'll keep it in situ and we'll go for an open surgery.
You will go for
Opening up. We'll open up from laparoscopy. We'll convert it into open
just for a trocar bleed.
because if intraperitoneal, no?
Yes, and from the abdominal wall.
From the
You put a trocar and there is a trickle from the abdominal wall.
From the abdominal wall, if there is a trickle, then we'll change the angle and we'll try to go in deeper.
And how do you control that bleed? You take transfacial sutures,
Yes.
right?
हेलो जैसा कि सर ने अभी बताया कि जब हम पोर्ट इंसर्ट करते हैं तो उस वक्त जो फोर्स अप्लाइड करते हैं वो कंट्रोल वे में होना चाहिए। कुछ साल पहले की बात है, इसी राममनोहर लोहिया इंस्टीट्यूट के डॉक्टर्स नाम नहीं लेना चाहूँगा, लेकिन मीडिया में काफ़ी कुछ ये हाइप हुआ था कि एक पेशेंट को जो कि जब ट्रोकार जब डाला था तो सीधे आईवीसी में हो गया था, प्रोफ्यूज ब्लीड हुआ था और ओटी में पेशेंट एक्सपायर कर गया था। तो फोर्स जो भी अप्लाई कर रहे हैं वो जो है कि कंट्रोल वे में होना चाहिए और लाइक स्पिनिंग।
Thank you.
Thank you.
ठीक है। Next